My name is James Udelson. I'm Chief of Cardiology at Tufts Medical Center in Boston and Professor of Medicine and Radiology at Tufts University School of Medicine here in Boston. So the study in the CAPACITY heart failure trial aimed to address the possibility that stimulation of soluble guanylate cyclase by a drug called praliciguat, which is an SGC stimulator, may improve exercise tolerance as measured by peak VO2 in patients with heart failure and preserved ejection fraction. We thought that there was a pretty high likelihood that some patients with HFpEF may have SGC and nitric oxide deficiency, particularly those who have the metabolic and inflammatory profile of HFpEF, as was described several years ago by Boros and colleagues. Well, SGC stimulators like praliciguat and another drug in that category, praliciguat, which has been reported on recently, stimulate soluble guanylate cyclase, which makes cyclic GMP more available and addresses the nitric oxide deficiency. And it may work in multiple tissues, not only the myocardium, but also the vasculature, possibly the kidney, may address microvascular abnormalities in coronary blood flow, as well as in the skeletal muscles. So it's conceivable that drugs in this category can have favorable effects in multiple tissue beds, which may address, we thought, the multiple pathophysiologic abnormalities that exist in patients with heart failure and preserved ejection fraction. This was a multicenter, randomized controlled trial. Patients who were eligible, I'll talk about that in a moment, were randomized initially to one of four arms, either placebo or one of three doses of praliciguat. Very early in the trial, emerging data from some other small pilot studies suggested that the lower doses were probably not going to be efficacious. And so they were dropped early. And ultimately, the study was a study of patients randomized to either placebo or a dose of 40 milligrams a day of this drug, praliciguat. Patients were followed for a total of 12 weeks. They were seen intermittently during that time for gathering of biomarkers and multiple tests. The primary endpoint of the trial was functional capacity as measured by peak oxygen consumption during cardiopulmonary exercise testing. This was done at baseline, at week 8 of the trial, and again at week 12. That was the primary endpoint. Secondary endpoints included quality of life measured by Kansas City Cardiomyopathy Questionnaire, multiple biomarkers, and multiple echocardiographic endpoints as well. And I should note that the cardiopulmonary exercise tests and the echoes were evaluated in core laboratories. You also asked about the inclusion criteria, and this is always a point of real interest in HFpEF trials. The steering committee, along with the sponsor, thought a lot about this, and we wanted to try and enrich the study with patients who had this metabolic inflammatory profile that Paulus described. You know, years ago when he first described this, he was able to do left ventricular biopsies in these patients to find the abnormalities in the signaling pathways. And of course, we can't do that for a clinical trial. And so what we did was build into the inclusion criteria that besides pretty clearly having heart failure with preserved ejection fraction by various criteria, that patients had to have at least 2 comorbidities, either hypertension, diabetes, obesity, or age greater than 70. And we hoped by doing that, we would create a population with sort of a clustering of comorbidities that would translate into those who had this pathophysiologic abnormalities. So that was a novel aspect that I don't think others have done in HFpEF. Another novel aspect of the inclusion criteria was that we did not absolutely require patients to have an elevated NT-proBNP, as is very common in trials like this. As long as they had multiple other aspects of heart failure to qualify. We did this because some studies in HFpEF have suggested that patients on the lower end of the BNP spectrum seem to respond better to therapeutic interventions, as was suggested in the iPreserve trial of irbesartan and the TopCat trial of spironolactone. It may be that the people on the higher end have too much fibrosis to respond, so we specifically built the inclusion in that way to try and get some representation of those types of patients. So the findings were pretty resoundingly neutral all around. The primary endpoint, peak VO2, at week 8 and week 12 of the trial showed no significant difference in the changes from baseline between the praliciguat group or the versus the placebo group. All of the secondary endpoints, all of the KCCQ, quality of life measures, did not show favorable benefits. One of the measures, in fact, showed more benefit in the placebo group than in the praliciguat group, even though both improved. Echocardiographic markers were all neutral, biomarkers were neutral, so it was pretty resoundingly neutral. You know, one of the issues when you have a neutral trial, you have to ask yourself several questions. Did we use the right dose? And was the dose too low to affect the pathway? That probably wasn't the case, because in the praliciguat group, blood pressure did go down 5 or 6 millimeters systolic. And in the praliciguat group, about 10% of the people had dizziness and hypotension as adverse effects, compared to almost none on placebo. So there was a pharmacodynamic effect happening with the dose of that drug. But somehow the pathway wasn't affected enough to improve peak oxygen consumption and functional capacity, nor on any other structural or functional or quality of life endpoint. It's possible that the trial duration was too short, that maybe it takes a longer time for these changes to affect structure and function and translate into some patient improvements that we can detect, but we certainly can't say that one way or another. I think, as you asked, the major lesson might be that trying to affect one pathway with a drug in a pathophysiologic entity that's as complex as HFpEF, may not be a fruitful exercise. If you look at the interventions which have improved functional capacity in HFpEF, and there's really only two: exercise over time, an exercise program, or caloric restriction and weight loss. Those interventions would be expected to impact multiple pathways and not really just one pathway as a drug might. So that, I think, is one of the important lessons here that was learned.